Hello, everyone. I'm super excited to be here. RTP180 is one of my favorite events to network, and thank you so much for coming. I'm really excited to tell you about HealthSpan. As I was preparing for a talk, I realized that in a couple of weeks, it's actually our 5-year anniversary. And we've been, somewhat dark for probably 4.5 years of this, so, here's a little treat. So today I want to tell you about the work we do in bringing measurement of aging into the clinic. So here's the problem. So as we age, we can, as we all know, things happen, and we can all suffer adverse events from, things that were not a big deal 10 years ago. And but while patients' age is a known risk factor, an obvious risk factor in pretty much every medical procedure, chronological age doesn't really reflect the difference in individual aging. And unfortunately, it's that molecular age, what we call molecular age, or decline of physiological reserve, is the underlying cause of the incidence of the adverse outcomes. And in the absence of measurements of physiological reserve, physicians pretty much have to guess whether the patient, is at risk. And let me ask you this. So let's say you walk into your clinician's office for, annual checkup, and they start asking you questions. Do you exercise? Do you drink? Do you smoke? What's your lifestyle like? How many of you are honest about your exercise routine? Or, and such. But it's really important because clinicians are trying to understand how fit are you, because the treatment that would be beneficial to you might actually be not so beneficial if you are in that, declined physiological reserve category. And more importantly, even if you are being honest about it, there's really no way for clinicians to incorporate that information. If I work out for 20 hours a week, and you do 40, does it mean I have twice as much risk? Probably not. What if I work out for 20 minutes, but also have a glass of wine? Does that cancel out the effect? So there is really no way to tell how all these things affect people, and it's not. Physiological aging is invisible. It's not the wrinkles and the gray hair. It's things that happen in your tissues that clinician really has no way of knowing. And unfortunately, when two 40-year-olds have the same procedure, one can have a adverse event and the other one does not. And they both would be considered low risk because they're 40, but the one that has adverse event can actually have really serious complications, and they might die, they might become disabled, or loss of a quality of life. And so it's a really important problem to understand that people are different. We all age at different level, and so how do we address that? And so our solution is the diagnostic suite that measures just that. It measures molecular age. And so we're positioning to use that test in a clinician's office as individual patient risk prevention, individual risk prediction, and to prevent devastating consequences of genetic treatment strategies to save life and improve health. And so as I mentioned, in general, it's obvious. Everybody's physiologic reserve goes up with aging, but there's a huge spread between individual people. And physiologic reserve is affected by things like injury and disease and treatment through your lifespan and genetics and lifestyle and environment, and how all these things interact with each other. So there is really no way to tell on individual level just by looking at the person. So the way we think about aging is the process called senescence. And normal healthy cell is happy to divide. If you have an injury, it's happy to divide and repair the tissue. And as cells age, or with insults, they become what we call senescent. That means the cell cannot divide, but it's not cleared out of the tissue, so it just stays in the tissue, and it accumulates the marker that is known as P16. So your young healthy tissue becomes slightly senescent, and then it becomes more senescent, and now the senescent cells are secreting inflammatory factors, so now you have this local inflammation, and if you aren't going some procedure or some medical treatment where your tissue needs to recover, you're out of luck. And there's really no better way to demonstrate this. So here are two mice that are of the same chronological age. Mouse on the left and mouse on the right. Senescent cells been pre-cleared, P16 expressing senescent cells been pre-cleared with therapeutic intervention, and I don't have to tell you, they're clearly different, and I would rather be the mouse on the right. And if you look at the humans, you obviously see the same thing. So if you look at the expression of P16, this was 170, quote unquote healthy volunteers. And as you can see, for example, in 50-year-olds, there is a huge variability between individual physiological age. So for example, at the 50-year-old mark, there was a 24-year spread. And, clearly that's really important, but clinician doesn't know about that. And, so P16 received a lot of publicity. We started out of University of North Carolina from Dr. Sharpless. We found it to address this really important question. So, okay, you can measure this, so what are you going to do with it? And I heard the pitch, and I knew I just had to be involved. And I left my 60-week faculty position at UNC to do 60-week at a startup with basically no money. And long story short, 5 years later, it's the best job I've ever had, and wouldn't trade it for anything. We've had just amazing amount of work that's been done. We've had amazing progress. So as I mentioned, we started 2013. We were really fortunate to receive a lot of funding. We have a commercial product in the cardiology space that is coming in the market in about a year. We have, just unbelievable team. You will be lucky to have just one of them working for you, and you can't have them. I have amazing medical advisor team that advises us on all aspects of it. We've perfected assay, it's automated, it's ready for clinical adoption, it's been validated on thousands of samples. These are just a small subset of research universities that use our services, and happy to do so. My team, and here they are.
All right. People have often described me as senescent, and I've just realized that's bad. All right.
I guess it depends.
It does depend. My kids are going to be in trouble when they get home. All right, questions. Do we have a question in the back? Is that a hand being raised? All the way in the back here, making me walk, become less senescent. Question back here. Here we go.
Can you tell me how how it's any different than looking at telomere testing or micronutrient testing that the doctors can actually do to look at the aging process and, of course, deficiencies and things like that that actually cause aging early?
Yes. So, the causing aging early, I would address first. So P16 is actually the first marker that is upregulating senescence. When definition of senescence is upregulation of P16, and maintenance of P16 is essential for maintaining senescent phenotype. So P16 is actually early. So that's one thing. And the second thing is, and I don't mean it because we don't measure telomeres, but telomeres, everybody's telomeres are different. And also, if you look at the population, the dynamic range of the change in telomere expression is very low. So if you look at a 20-year-old and an 80-year-old, the 95% confidence interval interrupts. So there are no telomere assays in the clinic. I mean, it's a direct-to-consumer test, but there are no telomere assays in the clinic for that reason, that they cannot be used on an individual level for precision medicine because they're not precise. There's just that. And there are a few examples of babies who are born with very short telomeres and therefore they have problems with aging, but so there are two rare diseases that are very specialized. Everybody else is pretty much within 95%. This is not like that. You don't have it when you're young, and then it goes up exponentially, and we've been doing trials and all sorts of indications for the last 3 years. We can tell a difference between people, and we can tell a difference between people who exercise and people who don't, and people who smoke, and So it works.
Next question is coming from back here. If you could please stand up when you ask your question to help the folks watching on TV.
Hi there. Fascinating work, and I'd be curious about kind of two things. One is, what's your IP position? Is it the diagnostic test or kind of the utilization of it? And two is, do you have plans to commercialize into pharma or otherwise beyond the academic partnerships and SBIR grants?
So, second question first. So we were fortunate to have grants, and we are really fortunate to have academic partners. That's what generates data. That's what generates proof of concept. That is obviously not sustainable as a business model. So we're very much looking into partnering with pharma, whether it's a clinical trial enrollment tool or guiding drug decisions, drug randomization tool. So that's ongoing work. We're very much doing that. The first question on AP, it's a diagnostic test, and that's all I can say on live TV.
All right, your next question is coming from here on your left. If you could, please stand up.
I'm a health economist, and I was curious if this research, this kind of diagnostic test has gotten to the point where you've taken it and put it in a model instead of age and saw different predictive outcomes, maybe more accurate predictive outcomes, or if this type of diagnostic test is at that point.
That is absolutely what we're doing. So it's basically just replacing the age with this, because when you say that older patients don't do better, you really mean this. So that's exactly the point.
All right, our last question will be coming from over here.
Great. I have two questions. The first one is, have you compared it to the recent DNA methylation age, which is very predictive, and do you see differences, anti-correlation there? And the second question is there a genetic basis to P16? So people just born with just generally elevated P16, or is it purely environmentally and lifestyle determined?
So all excellent questions. I'm very impressed. I thought it would be a mixed audience. So methylation, absolutely yes. And so we have a collaboration with Steve Horvath to do just that, who is a leader in methylation. And there are differences. So methylation seems to be much tighter related to aging, whereas P16 is not. So P16 seems to represent more of the, environment stress, if you wish. But we are doing studies where in different populations where it's a head-to-head comparison. And we do see differences. We see indications where methylation and P16 may be performing the same, but we're also seeing, and we are the only commercial company that actually is commercializing it, whereas methylation test is not. So that's one question. And the second question, what was the second question, sorry? Yes, fine. Oh yeah, yes, so there is, yes, sorry. So yes, so there are some people where, so the bad thing about aging markers is early on, they actually serve as tumor suppressors. So there are some people that are born with mutation where they don't have P16, and that doesn't mean they will live forever. That means they will have cancer early. So there are definitely people, so early on it's protective from cancer, and then it becomes an aging nuisance. And so people who have low P16 succumb to cancer, so it's not necessarily benefiting them.
All right, please give it up for Dr. Mitin.